uterine curettage for retail products, uterine artery ligation. This can be bilateral and also ligate uterovarian vessels, and together it is called a stepwise devascularization of the uterus. Use of a B-Lynch suture, a hypogastric artery ligation or internal light ligation. This is now considered to be less successful than was earlier thought. It is difficult, generally reserved for people who are experienced in it, and the problem is that if you have done internal light ligation, you cannot later on do an embolization because the path of the catheter is blocked. So this is, with the advent of availability of embolization, its role is now has to be rethought as to where it has a role. Repair of uterine rupture and hysterectomy. If a woman has had a vaginal delivery and not a C-section, we can still use compression sutures without opening the uterus as shown below. They can be of different types. The idea is to tie the two walls of the uterus together with an absorbable suture. Other surgical procedures like devascularization, internal light ligation or hysterectomy may be attempted depending upon patient to patient. Coming to scenario 2. Those procedures I will show you at this time of scenario 2 because when PPH is the time of cesarean section, the procedures will be common. So when to expect, specifically in cases of placenta previa, during placenta or a previous PPH, we should be prepared of the PPH time of C-section. Here, what is different from what we've done, uterus exteriorization helps to visualize and to keep the uterine arteries and gives you time to see the site of bleeding and the source of bleeding. Intramyometrial PGF2 alpha may be used, and this should be diluted and given so that it can cover a wider area of the myometrium. Uterine compression sutures like B-Lynch suture and uterine devascularization. The B-Lynch suture, we have a video to show it. I think we'll skip that video.
What the final demonstration there? The
that will come in the end. That is BLS part of it. Because that video is a little lengthy one. I am sure all of us know the B-Lynch suture and we just have to, or later on if there is time I will go, but right now I think. Rather we'll show you two different videos of the stepwise uterine devascularization or internal light ligation artery. Like I mentioned, its limitation is that it will preclude the rule of selective embolization. It will take care of the main hemorrhage by reducing the blood loss. But if you have collaterals which you need to address by selective embolization, the path of the catheter is blocked. And hysterectomy also may be attempted. A peripartum hysterectomy or cesarean hysterectomy is different from a regular hysterectomy because the tissues are edematous, vascular and friable. They have to be handled gently. Bladder separation has to be done meticulously. Sometimes if it is an advanced labor, it's difficult to identify where the cervix ends, where the vagina starts. Ureter must be identified. And this is a picture, if you've seen in the antenatal period, this is the kind of C-section if you're attempting with a morbidly adherent placenta where you must be prepared for all kinds of hemorrhage. The preoperative planning has to be done right away in the form of getting extended cross-match of blood and having the checking with the inventory of the blood bank, which hopefully we haven't depleted completely when we are arranging for more blood for this patient. And decision regarding hysterectomy has to be taken beforehand. Urologist may be needed if the bladder is also adherent. And sometimes in certain OTs, I was actually discussing with a colleague and they mentioned, Dr. Sunil Jain from AIMS, he mentioned that they have a C-arm in the OT and sometimes they call the radiologist there and they have a catheterization of internal lights before doing this procedure, which is something which we have never done. But since it was done there, I thought I'll mention it here. Intraoperatively, we can either do a conservative management to preserve fertility without attaching the placenta, expected management, MRP later. Again, it has to be it is fraught with problems like delayed hemorrhage and infection. This has to be discussed beforehand and only done if the patient is very keen to preserve fertility and agrees to take the risks. If you have a very focally adherent placenta, we can do a wedge resection at the site of the.
What is the need of devascularization when the conservative management has exhausted? Reproductive function needs to be preserved as life-saving procedure in emergency and as a prophylactic measure. Like for you are doing a cesarean section for a living placenta, you can electively plan this. Justification for vascular occlusion: 90% blood supply to uterus during pregnancy comes from uterine arteries. Occlusion of uterine arteries reduces most of the uterine blood flow, so that's the justification. A occlusion of ovarian vessel results in additional deprivation of uterine blood supply. In uncontrollable hemorrhage, the feeding arteries lose their ability to constrict. So ligation does play a role there. Vascular occlusion is a temporary procedure. Recanalization appears to be the rule, anatomically sound and physiologically rational. So what is stepwise devascularization? You go step by step. You don't have to do all the 5 steps in a patient. Step 1 is unilateral uterine vessel ligation. That's in cases of if extension of uterine incision has occurred on one side or uterine artery laceration has occurred. Step 2, bilateral uterine vessel ligation in case of uterine atony and abruptio placentae. Step 3, low bilateral uterine vessel ligation in case of lower uterine segment hemorrhage like in placenta previa or placenta previa and accreta. Step 4, unilateral ovarian vessel ligation if a limited part of the uterus has become coagular. Step 5, bilateral ovarian vessel ligation. Internal iliac artery ligation is not a part of stepwise devascularization, but I thought I will tell that also once in a while when the patient is open in front of you, rather than closing abdomen, sending her down for embolization, you should rather attempt and try intravesical ligation. So procedure of uterine vessel ligation. Uterus is grasped with hand, elevated interiorly and to one side with 4 fingers posterior surface and thumb over the lower uterine segment so that you will be constricting the uterus also at the same time. Uterine artery is ligated at the level where it runs along the uterine border beside the upper part of lower uterine segment. A large Mayo needle with number 1 atraumatic chromic catheter is passed through the avascular area of broad ligament and brought forward through the myometrium and tied. It should be atraumatic, it should be large needle, it should be atraumatic large needle number 1 catheter, not vicryl, not silk, not nylon. If there is vaginal delivery, you can do it extraperitoneally. At the time of cesarean section, the suture is placed below the uterine incision under the reflected peritoneal flap. So when this is how you
Rashmi, इसका वो जो marker का point है.
okay. This is the uterine artery, just on the side and little below the end of your incision, taking a part of the myometrium, come out through the transparent broad ligament. And this is how the part of myometrium must be taken into that and tied. The low bilateral uterine vessel ligation is reserved for cases who continue lower uterine segment hemorrhage at cesarean section, not controlled by initial ligation. It is step 3, not 2. Bladder needs to be well mobilized low. 2 to 3 centimeters below the upper ligature, another ligature is placed where its cervicovaginal branch turns upwards. This ligature will obliterate most of the branches of the uterine artery to lower uterine segment and upper part of the cervix. Uterine artery ligation by vaginal route also has been described by one author. So, this is the upper, the conventional uterine artery ligation, and this is at the lower level when you take the cervical branch going up. So, what is the need of ovarian vessel ligation? When you think that this will help, bleeding is still not controlled. Ovarian vessel ligation can be done by 3 methods. Very simple is tie the infundibulopelvic ligament. But we don't want to tie that. That's a very simple method. As a life-saving procedure, maybe once in a while somebody can attempt that, but I will not recommend that. The other 2 methods are in the mesovarium. With help of right angle clamp, through the avascular area, press a free ligature and tie the ovarian artery. Or you can ligate the ovarian artery at its anastomosis with the uterine artery in the medial mesosalpinx at the uterovarian ligament, including myometry. Ligation 74.8% effective disease. And when all the 5 methods are used, 100% effectiveness has been shown by a good study from Egypt. And then just bilateral uterine artery ligation, 80 to 92% effectivity has been shown. Life-saving alternative to hysterectomy. So this is just diagrammatic representation, uterine artery ligation, and then where the anastomosis of ovarian and uterine artery ligation is occurring. The complications are minimal. In fact, I would say no complications. Broad ligament hematoma, just in case your needle has gone through the vessel. And ureteral bladder injury should not occur in our hands. The obstetricians who are so used to the ureters and the bladder, we all are rather more cautious of injuring these. When the anatomy is distorted, rupture uterus badly distorted, then it is difficult to do stepwise uterine vascularization. Bleeding from vaginal lacerations and cervical tears will not stop by this procedure. There are no long-term adverse effects of this procedure. Now, internal helical artery ligation, we do need it at times as a life-saving procedure, or when you do not get consent for removal of the uterus and you have opened the abdomen, you are there, you can do it. This is a time-tested life-saving procedure, and it decreases pulse pressure by 75 to 85%, reduces blood flow by nearly half. Arterial system changes into venous flow, and easier than uterine artery ligation in face of massive hemorrhage and distorted pelvic anatomy. Clear concepts of pelvic anatomy are must before you ever attempt the internal helical artery ligation. This does require skill and experience. So, the peritoneum is incised medial to the ureters, or you can incise it between the round ligament and the fallopian tube. And you have to identify ureter, you have to identify common iliac artery, you have to see external iliac artery and internal iliac vein, then only put the ligature on the internal iliac artery. And this you will do with silk, not with cat, with Vicodin, not with nylon. The femoral pulse must be seen after you ligate this vessel. So to conclude, stepwise uterine revascularization is effective, safe and life-saving alternative to hysterectomy. Bilateral uterine artery ligation ideal for uterine atomy and abruptio placenta. Ideal procedure for placenta previa and accreta. Ideal in severe PPH bilateral internal helical artery ligation when the pelvic anatomy is distorted. Pelvic vessel ligation expertise should be present in the armamentarium of every gynecologist to control hemorrhage then and there rather than searching for other specialty experts. We should all become expert in these vessels, identification and ligation. We should not plead to the urology and surgery for this. Primary objective of such a program should be to instill confidence in the technique in a non-stress environment. We can identify at the time of hysterectomy, we can show to the residents these internal vessels, uterine artery vessels. But it is inadvisable to perform ligation of big vessels for the first time in a desperate situation. Thank you.
When the patient has to be transported or referred to a higher center with postpartum hemorrhage, we need to have a checklist. The patient should be kept warm, intravenous access, 2 lines running, uterotonics having been given and already say oxygen infusion running, preferably with a tamponade. Bakri is a little costly, but condom catheter is very inexpensive and works just as well. Oxygen on flow, urinary catheter in situ. If facilities are available and the patient is accompanied by a doctor, it's handy to have a pulse oximeter and a small monitor also, and use of an anti-shock garment. So, I would just like to show you 2 small videos now of maneuvers to control bleeding, to reduce bleeding and maintain BP in desperate situations. One is an aortic compression and second is the through the